Good morning. I'll be talking on image publication and scientific communication, how and where to share clinical photos. So this is an interesting image of a traumatic end of secondary player fish injury while swimming in a pond. You can see that we have pulled the fish cartilage from the eye, and this is the entire section. So this is a second image of a normal retinal tear just temporal to the macula. You'll all be thinking that the first image was much more interesting than the next, but we published both images in reputed journals. So why the second image? So here you see this is a 25-year-old male who came to us with an history of trauma. This was during my fellowship and I saw him in the prelims. I saw a retinal tear, but what caught my attention was this black line running along the length of the tear. So anyone can say what this is? Just a guess. You can be loud. Yes, it's an eyelash. So I didn't identify it at that point in time, but I went to my senior and I asked him what it was. He told it was an incarcerated eyelash. And the next question I asked him was, how often do you see an incarcerated eyelash in the retina, secondary to a trauma? He told in his 8 years, he has seen 2, and this was the second one. So we went on to publish this under ophthalmic image in IJO. So always be curious whenever you see a case in OPD. When you don't know the diagnosis, go to your senior. They will see whether it's a rare or interesting case, and that will give you a clue whether to publish it or not. So this is a brief session overview of what we are going to cover. So this is the entire publication spectrum, starting from clinical image all the way to the original articles. But only image driven comes under clinical image, which is completely image driven, and letter to editor case reports are partially image driven. So now we have seen the patient, and now we want to document the photo. So along with the patient, we have to send a note to the technicians saying whether if it's a fundus photo, whether you want only the macula or you want to cover the periphery, whether you want a montage image, whether you want to use a wide field camera like a Claris or Eden or Mirante, or an ultra wide field where you catch the periphery in detail like Optos. So along with the color image, whether you want any other images like autofluorescence, multicolor imaging, that also will have to be told to the technician. And the last but the most important one is a focus or a defocused image. So what is a focused image? So this is an image of a corkscrew vascular loop over the disc. So here in the first image, you are able to see the background of the retina very clearly. But here the loop gets lost in the detail. So the second picture is centered over the loop with the background hazy. So this gives a much more clearer what is the image of focus this picture gives. So this won the merit award in the recently concluded APO meet in Hong Kong. So this, anyone can tell what this image is, what modality and what is it? What is the diagnosis? Yes, fleck, it's a white family. There's fundus albipunctatus as well as benign fleck retina. This is an autofluorescence image of a benign familial fleck retina. This got accepted as a cover image in Canadian journal, but the color picture of the same got accepted as a cover picture in ophthalmology. So one patient, 2 different set of images, 2 different publications. So this is a very interesting case. So here is a 40-year-old male who came to our apartment with complaints of near vision deficit. But on examination, we found a brownish cyst floating in the vitreous cavity. So remember, it's a phakic patient. So, but the clue is in the B scan. So can anyone just guess what this is? Can I have a mic to, if anyone is coming out with the answer, they can use the mic. Just a guess, anything is fine. So yes, cyst is fine, but what cyst? No, that's why I told you look at the B scan. I don't know, someone is saying iris cyst. It's a dislocated iris cyst in the vitreous cavity. Okay, it looks like a brown cataract, the dislocated brown cataract, but it's actually a dislocated iris cyst. This also got published in one of the reputed journals as a photo essay. you get cyst irises, but not as big as this one. So now you have documented the picture. Now you go on to write the narrative. So it four parts, with two parts being very important. One is the title, because images are basically 100 words, 100 to 200 words, and within that you'll have to capture the reader, and especially the one who's reviewing your article. So the title is very specific. Avoid vague titles. Finding is your title. Okay. And the second will be a clinical description. Don't spend a lot of words on it. Around 20 words is enough. But the main point where you should focus is the teaching point. What does the image conveys? That is the image conveys. What does the image say? It can be how you manage the case, how the pathology happened, or whether you used any investigation to come to the diagnosis. So this is a 12-year-old boy, history of trauma with a bicycle handle, diagnosis piece. Everything is there. The first two pictures gives you the diagnosis, A and B. There are three pathologies here. I have given that also. So one is a CRAO, and when you see these hemorrhages with CRAO, be sure it's a combined occlusion. And second, in the color photo, you see a normal retina patch, just nasal temporal to the disc. So that means when you see this finding, FFA, there will be a patent cilioretinal artery. Okay, so it's a combined occlusion with a cilioretinal artery sparing. Yeah. So this is a normal retina. This is a ischemic macula, and this is a patent cilioretinal artery that can find on FFA. So we submitted this for ophthalmology retina, and the editor wrote to us back nice images, but please add every submission has to have a learning value. So please add a possible pathogenic mechanism for this occlusion. So we went back and we wrote the likely mechanism could be a combination of tissue trauma-induced soft tissue edema with reflex vasospasm at the level of lamina fibrosa, and it got accepted in ophthalmology retina and got published. So what are the types of image publications? You've got clinical images, you've got image challenges where you give a set of questions based on the image, and then you've got photo essay series, you've got cover pictures, and then case reports with images. You should also remember case reports on its own won't be sufficient. You should have a good set of images also. So what makes an image publishable should be clinically relevant, a rare or classical finding, or a first description of a novel case. The main two things are image quality. It should be sharp, there should be no blurriness, and there should be no artifacts. And teaching point is very, very important in any image related publication. So all these have been taken previously, just rush through it. All the journals will require a minimum of 2 megapixels with 300 dpi for almost all journals. Take multiple photos of the lesion and select the sharpest one. And if you're taking the fundus photo, take it in a dilated state. Don't compromise on dilatation, because with mid dilatation of small people, we'll get a lot of artifacts. Second, post-processing, save it in TIFF or JPEG, and when you're labeling it, use the top right or bottom right corner. And arrows are preferred over circles for pointing out any lesion, and retain the original raw files. So ethics of image manipulation, I usually touch up, but don't do extensive manipulation of the image. Avoid removing, duplicating, or splicing any of the image. And if you're using AI, always say yes to the AI consent form, which is available in almost all journals nowadays. So this is the most important simple rule. Anything that identifies the patient, get the patient consent. Very simple. It's a very simple rule. Anything that identifies the patient, get a patient consent. Be it that's a de-identification checklist in almost all journals. Remove the name, date of birth, or the hospital ID from all image metadata. And first of all, when you're using the seeing the picture on the EMR, don't just screenshot it, edit it, crop it, and send it. That won't do good. Always ask them to send the raw file to you by mail or Google Drive. So coming to the various journals, I'll just start with the top tier global general journals. These are New England Journal of Medicine, Lancet, and JAMA. They all have got dedicated image sections. They are high impact factor journals, but very difficult to get into it. So coming to ophthalmology journals per se, international journals, so top tier being ophthalmology family of journals like ophthalmology, ophthalmology retina, ophthalmology science, and ophthalmology glaucoma. followed by Eye and Canadian Journal of Ophthalmology. All these three have dedicated image sections, both online and physical. Coming to subspecialty, I've got cornea, glaucoma, and in retina, I've got three journals like retina cases and brief reports, and I've got JVR, the Journal of Vitreoretinal Diseases. And coming to Indian journals, you've got Indian Journal of Ophthalmology, that is this section 1 minute ophthalmology. And then you've got IGO case reports, under which there is photo essays and original article, ophthalmic images. State journals, Kerala Journal and Tamil Nadu Journal have dedicated image sections. And recently, Tamil Nadu Journal have started cover pictures also. So coming to my very own publications, these are a few publications that I have done as cover pictures in ophthalmology over the years. I started doing this in 2022, and now I got around 4 in ophthalmology. So the single image centered for the cover image of the journal selected by the editor. So the first picture is a benign familial fleck retina, the autofluorescent image which I showed in the start of the presentation. So second one is again a CRAO with cilioretinal sparing, secondary to polycythemia. Third one is a classic image of BKH with serous detachment. So submitting a cover picture is very easy. Just send a mail to the editor with the image, and if accepted, they will reply back to you. Few things to remember in our submission to ophthalmology. Only 2 submissions per person in a year. It starts in February first week and ends by February end. And if accepted, the notification comes in early April. And these images are usually published within a year. The editor contacts you saying when the image will get published. And rejections are also equally high. 1 in 6 images get accepted in ophthalmology that you send. So the second journal that I usually submit if it gets rejected in ophthalmology is Eye. Though the first image is that of a choroidal granuloma. Can anyone say what is this finding here? Some thick whitish thing that is here. What is it? You know hypopyon in the AC, anterior segment. This is posterior hypopyon. From the granuloma, it starts leaking and settles here. So second, this is an image of the alveonotic fundus. Anything unusual in this case? Anatomically. Which is the disc? Again. Huh? No. Which is the disc? This one or this one? Okay. Even I got confused initially. So the thing is that usually the vortex veins are seen near the equator. They are never seen right next to the macular area. So here it was very striking that the vortex veins were just next to the fovea. So I just sent it as a cover image, got accepted. So the third image is that of anyone? It's a choroidal melanoma. So cover images don't need to have a teaching point, but if it's very interesting, very rare, can always send it. So coming to ophthalmic images, so here you use 1 or 2 figures, but the image is the article. You can describe it in within 100 or 150 words with few references. It's like a best for a clear sign or as a teaching image. So this is a 45-year-old male who presented to us after a spine surgery with defective vision. 1 day immediately after a spine surgery, he was very disoriented. So on examination, his right eye was PL and left eye was 624 in the morning with dilated and tortuous vessels. But by evening, that also dropped to around 1/60 with a full-blown RVU. So this was a perioperative or a post-operative visual loss, POVL we term it. And this also got accepted in an eye as an image. We couldn't do any other testing like FFP or anything because of the physical condition of the patient. So second is photo essay. It's a short series of images that tells a visual story. So this is a very interesting case. It's an 18-year-old girl who was referred to the retina OPD for getting clearance for YAG PA. So on examination, his left eye, the angle was shallow, the AC was shallow, a few cells were there, IOP was 26 millimeters of mercury, and fundus showed us multiple serous detachment similar to what we get in BKH. What we also should remember as PGs and fellows, you should remember that VKH can produce uveal effusion. Uveal effusion in turn can sometimes cause an angle closure. Okay. So this patient underwent 1 injection of IVMP And the next day, the angles opened up. You see here, the angles are closed. Here, this is an ASOCT image. Here, the angles are closed. And here, after the IVMP, the angles have opened up. The IOP also dropped to 12. And here, I never used any clinical image. I just used the investigative OCT pictures alone and got published as a photo essay in retina. So diagnosis again. These are all very classic examples that I'm showing you. So what is there in the first picture? This is an Optos picture. What is there in the first image? Is there any difference between these two images? Okay, I'll give you one clue. Before and after dark adaptation. Oguchi disease showing the Miso Nakamura phenomena, classic Nakamura phenomena. So we submitted this for 1 minute ophthalmology. It's a short image quiz with 1 or 2 pictures, a question with 4 answers, then the answer followed by short discussion. It's available in JAMA as clinical challenge. So we published this in IJU. So we have covered the journals. Now we come to image banks. There are prominent image banks. The most famous is the ASRS Retina Image Bank. Right now it has got around close to 45,000 images pertaining only to retina and fundus photography. So you just need to create an account and start uploading pictures there. They have got image of the month and image of the year. And if it gets selected image of the year, you get a free travel to US for the annual retina meet. So second is your AAO iWiki. They have short video, 1 minute video compilation as well as clinical images, fundus images, anterior segment images also. And EVRS Image Bank was started recently. It started by the European Vitreoretinal Society. They got, it's basically a retina image bank. So a short note on imaging competitions. So the most prominent one is the APOIS imaging competition that takes place annually during the APO meet regularly for the last 6 years. And if they got 3 places, they got 6 sections in it. And if you're a winner, you get free registration also. So the next one is Ophthalmic Photographer Society. This is mainly for the technicians, ophthalmic technicians who take fundus pictures. You can always upload it here. And they have got, it's a very prominent society where you have got competitions under 24 sections in ophthalmology, 24. And you get also image of the year, image, and then images under each section. And their annual meeting takes place along with the ACRS, I think, every year in the US. So when it comes to social media, when you're using social media as a publication platform, the same consent rules apply as for your journals. So watermark with your name and institution, and don't publish it on social media before the journal embargo lifts, because pre-submission sharing may affect novelty claims. Okay. So start by building your image portfolio, start archiving and documenting your images, and always match your image to your particular journal, because half your work is done there. If you match your image to your correct journal, the chances of it getting published is also high. So you can't just put a random picture in an anti-segment picture in a retina journal or a retina-based pathology in a journal. So just match your journals correctly. So common mistakes: don't submit any image with poor image quality. That will be instant rejection. If there is no clear teaching point, this is something that we get often from the editors. It's interesting but not publishable because it doesn't have a teaching point. Don't over manipulate your images. Minimal touch-ups is fine, but over manipulating your images, avoid it. And whenever, simple rule, anything that identifies the patient, get the patient consent. And do not select a wrong journal. If there's a scope mismatch, there will be instant rejection. And too many images, one single image beats 4 weak ones. So curate ruthlessly. So take home messages. Every image you capture as a potential publication, a good quality image with a good teaching point is always publishable. And match the image type to the correct journal. Write the teaching point first and build the description around it. The ethics of image manipulation are non-negotiable, and start building a systematic image archive. So thank you. I also thank the photographers and the ophthalmic technicians here, because most of the images that I've shown here are done by them. So thank you also.